uh, deliberations in the background after a compelling and talk by Piki, which has made us all think in many different directions. Their thought process, their uh, work speaks for themselves, and we have picked up the panelists who are not only having the expertise but also have the honesty to confess the limitations and set a way forward with do no harm kind of a mindset. And so I would now ask Purni Narayan to kindly introduce our panelists very briefly, please. Purni, kindly.
Thank you, ma'am.
Yeah. Yeah.
Thank you, ma'am.
Mm.
We've had such a wonderful beginning to today's program. The talk by Dr. Pikina was brilliant, and I'm sure all of you are looking forward to the case-based panel discussion on evolving trends in high risk pregnancy management. None other than Dr. Hema Divakar will be moderating this session. As we all know, Dr. Hema doesn't require an introduction, but to complete formalities, she is the CEO and chairman of ARTIST, which expands as the Asian Research and Training Institute for Skill Transfer, with the FICCI Award for Excellence in Capacity Building. She's the Division Director, FIGO, Well Women Healthcare at FIGO. She was the past president of FOXI 2013, an advocate for delivering quality healthcare, convener, Manyata. She's an opinion leader and an influencer for social and legal issues relating to women's health. We have a galaxy of panelists today. We begin with the first of the panelists, none other than Professor Dr. S. Sampath Kumari. She is the President OGSI 2025-26, Vice President FOXI 2022-23, Member FIGO Committee on Adolescents and Youth Health 2024 to 2027, Member Onco Committees AOFOG and SAFOG, National Corresponding Editor of Yogi, Senator Member Tamil Nadu Dr. MGR Medical University, Chennai. Our next panelist for today is Dr. Chinmayi Ratha. She is the President, SFM Telangana Chapter, Chairperson, FOXI Perinatology Committee 2021 to 25, Member Scientific Committee, IMA Telangana 2023-24, Member AICC RCOG IRC South Zone Committee, Director and Lead Consultant, Resolution Center of Fetal Medicine at Hyderabad, Senior Consultant, Fetal Medicine and OBGYN, KIMS Sunshine Hospital, Begumpet, Hyderabad. She's a visiting consultant, fetal medicine, Aret Hospitals at Hyderabad, Center Head, ICOG, FM Certification Course, FMF, UK Approved Examiner in India, and she's an MRCOG Part 3 examiner. As you all can see, she's a receiver of multiple awards, just to name a few. Dr. Mehru Hansotia Award for Best FOXI Committee Chairperson 2025, AICOG Mumbai. Dr. M.V. Paranjya Oration Award, Satara OBGYN Society 2024, FOXI Dr. C.S. Dawn Prize for Best Oral Paper, AICOG 2024, Professor Kamal Bakshi Oration Award in Fetal Medicine, SFM Fetal Medicine, New Delhi 2023. Our next panelist for the day is Dr. Vidhu Mortil. She's the Director and Senior Consultant, Suman Hospital, Ludhiana, obstetrics and gynecologist. She's an infertility and cosmetic gynecology specialist. She's a fertility expert since the last 20 years in New Life Infertility. She's also practicing at the Suman Hospital. She was the past president, Ludhiana Obstetrics and Gynaec Society 2019 to 21, and past secretary, Ludhiana Obstetrics and Gynaec Society 2017 to 2019. Our last but not the least panelist for today is Dr. Shalini Jaggi, Consultant and Director, Life Care Diabetes Centre, New Delhi. She's a Fellow of Royal Colleges of Physicians of London, Edinburgh, and Glasgow, Fellow of the American College of Endocrinology, United States of America, Fellow and Chairman, RSSDI Delhi Chapter, National President and Governing Council Member, DIPSI, serving Asia Pacific Advisory Board Member, American College of Endocrinologists, AACE, Chair, Diabetes and Mental Health Interest Group, Diabetes India, ex-national EC member, RSSDI 2018 to 2022. She's the recipient of the RSSDI Woman Diabetologist of the Year Award 2023 and Woman Icon of the Year 2022 Award, and also the recipient of ACT India Community Service Award. Over to you, Dr. Hema, for moderating the panel.
Thank you. That was a good breather for the intense discussion that we had prior to beginning the panel discussion per se for today. And we would be happy to reflect on so many of the pointers raised not only by Piki in her keynote, but also by the esteemed delegates who have been thinking through what we should be doing in practice. So, women's wellness on wheels, as we call it, we want to empower every girl, every woman, everywhere through the technology base. And this is one such fantastic example of the Webinar Connect, where hundreds of you have joined in. Also, we'll be seeing the recording later on. And on the rolls, there are about more than 7,000 registrants. So sooner or later, you will get to hear what the experts have said. So once again, with my very warm welcome to all the brilliant panelists with such a strong background that they have had, and you have just seen Dr. Purni deliberate on that. Keep your questions going, because I will tuck in the audience questions in between, if not at the end. And we want to see the trends of management of high-risk pregnancy in general. How do we investigate them? How do we interpret these investigations? Because that is one of the biggest challenges that we have faced when patients come for second opinion, third opinion, go shopping here to there. They get a lot of tests done, but each provider interprets it a little bit differently, and the counseling that they receive only confuses them many a times and leads to much anxiety. The last but the most important point: what will you do with all these investigations and interpretations? Is it time to intervene? So that is the essence of what we may take. Can any one of you just confirm if you're seeing my slides
Yes,
properly?
ma'am, it's
Yeah,
visible.
great. Okay, so one simple case, just an illustrative case. Mrs. X, first pregnancy was way back when she was only 24 years old, and young primaries typically severe preeclampsia, landed up with an intrauterine death at 20 weeks of gestation, never had the guts to conceive for the next 10 years. Now she's already 34, and she didn't expect a pregnancy, but she's now 10 weeks pregnant, and she has landed at your doorstep. All my panelists, one rapid fire: the high risk for recurrent preeclampsia and adverse perinatal outcomes. Yes or no? Vidu?
Yes. Yes.
Yes,
Chennai?
madam.
Yes.
Yes, ma'am.
Sampath?
Yes, madam.
Shalini?
Absolutely, ma'am. 100%.
Picky, if she's still around. Picky?
Yes, ma'am.
Oh, great. Okay. So then this we have agreed upon, that this is one thing that we always lean on. And first of all, no live issues, and then we have to support her in this pregnancy with all that we can do to help her take home a live baby. So now this is one warm-up round. Sampath Kumari has dealt with thousands of staff nurses to do some basic evidence-based requirements, as in our flagship program of Foxy Manyata, and to assess the baseline blood pressure. Sampath, you'll agree with me that in the pre-test and in the center assessment, we found that even blood pressure was not routinely checked at every visit. So the ideal way of taking the blood pressure, how do we teach these frontliners? Because I don't think the super consultant at any hospital actually measures the blood pressure by themselves. It's always the staff nurses who are there to help. So have you found a setback or a challenge right in the basic measurement of blood pressure, Sampath?
Yes, madam. Definitely. First of all, thanks for the opportunity, madam. There is some communication problem. See, the taking the blood pressure itself is really important. When we were doing the helping mothers survive, I used to go to the PHC and the primary health center. Most of the time, some people, they do take the blood pressure in the standing posture of the patient. So we should teach them that blood pressure should be taken in the left lateral position or in the sitting position with the BP apparatus and the heart burner, everything in the same line.
Right.
And about 1 centimeter about the cubical fossa. Appropriate cuff, that is very, very important. In some place, they also use the pediatric cuff for a BMI of a woman with a 35. So that the measurement of the blood pressure alone can reduce the complications of hypertensive disorder in pregnancy.
Right. Yeah. Thank you so much, Sampath, because this is the ground reality in our country. And then one small take-home message for all those with the small, medium-sized nursing homes, any new recruitee, any of your old staff, please help them teach the right method of taking the blood pressure to all your frontline staffs who are commonly involved, both in your outpatient and inpatient, because please do not presume that they will be doing things right. And that could be a start point of a miss when with such a low hanging fruit of just checking the blood pressure and alerting the consultant would be of great help. Now, Shalini, uh, baseline and follow up in this patient, you know, as we just spoke, sometimes too many things are done. She is coming to us at 10 weeks. What are we expected to do? In such a case, 10 years ago, she's had a bad, incident of a severe preeclampsia. Now, in the middle, she's never ever gone anywhere. So, do you do renal function test, liver function test, this, that,
Absolutely,
and the
ma'am.
other? What is your advice?
She needs the entire gamut of a preconception workup that we do routinely for all patients. You need to even look at her glycemic levels. What
Mm-hmm.
if she's already developed pre-diabetes or she's turned into a diabetic? So, even if she's pre-diabetic or not, the age with bad obs history, again, the common soil for preeclampsia, diabetes is all metabolic dysfunction, insulin resistance. So you definitely need to look at her HbA1c levels, do a random glucose as well.
Right.
Maybe look for GDM if you want to do a GDM screening. That's best. We always say, preconception you should rule out, but at
Mm-hmm.
least first visit, ANC visit, you need to do, you need to rule out, screen her for GDM as well. Then a complete renal assessment, her GFR, you need to see what is her serum creatinine, BUN. You need to look at her uric acid. Increased uric acid is also an indicator of endothelial
Mm-hmm.
dysfunction associated with, both preeclampsia and GDM. So you need to look at that. You further need to do a complete baseline investigation in terms of LFTs, look at her vitamin D levels, calcium,
Mm-hmm.
PTH. All these things are very important. Her serum iron levels, basic CBC, that is going to tell you what is her hemoglobin, what is her total platelet, what is her hematocrit. So I think you need to do a complete baseline investigation to rule out any pre-existing comorbidity that she may have developed, which could have an
Mm-hmm.
adverse impact on her current pregnancy. As well, you need to look at the, anything that can harm the fetus as well. So I think we need to do a complete routine, including most of the parameters that we look at: an LFT, a KFT,
Sure.
urine
Shalini, in
protein,
tertiary care
USR.
hospitals, when the cross referrals is kind of a possibility, do you think it's better to send them to people like you once if we are working in a multi-specialty hospital?
Absolutely, ma'am. I think one referral to a diabetologist or an endocrinologist should definitely be done. And, my request is at the level of preconception, if that is possible.
Mm-hmm.
Otherwise, at first ANC visit, when she comes, you must, even if she's not developed anything, you should just send her for a routine so that, we can look at everything.
Okay.
Something as
Okay.
simple as a fundus examination, which we don't do. And then suddenly you will see a proliferative retinopathy happening in second or third trimester, which is
Yeah.
very common these days.
Yeah, because what
So I
happens,
think,
Shalini, is in practice, if some of us start doing all of these things, and there is such a narrowing rapport between the trust deficit between patients and
yeah,
the consultants, they think that, oh,
yes,
they are just fleecing us for everything. They're doing from
yeah,
A to Z because that's a real concern. And they go to the neighborhood doctor and who says, no, no, you don't need all these things.
yeah,
You can just these key things because you've already gotten pregnant. Now, what's a big deal?
yeah.
So these are the kind of setbacks that happens in real time, real life practice. So I think the point is well taken that especially in cases like these, and also if the opportunity, one check so that we don't miss anything
Yes.
because we are all talking about missed opportunities to take a proper blood pressure, missed opportunity to assess her major organ function and dysfunction, etc. So I think it is at least a helpline from all of you is really
A
a
routine
worthwhile thing.
baseline ECG is so essential,
Okay. Mm.
which we don't do initially many times. So I think my request would be a cross referral to your physician or an endocrinologist or a diabetologist, depending on whosoever is available, for a
Yeah.
complete assessment of her otherwise metabolic health.
Sure. Okay. Thanks, Shalini. Now, Vidhu, she spoke so much about no, you have to do a, glycemic status, especially focusing on the GDM. Do you think this patient is also at risk for a GDM, Vidhu?
Thank you, ma'am, for this opportunity. And definitely, keeping her previous history in mind and keeping her age in mind, I think so. She is on a high risk of developing GDM,
Mm-hmm.
which, because as we know, we have already, Picky ma'am has also said, that these kind of patients which are usually deficient in vitamin D and magnesium, so they develop all these complications. So keeping in that mind, we should also check her up for all her
Yeah,
glycemic.
because just because she's landed with preeclampsia, focus is not narrowed to that. It's all these other very high possibilities of coexisting comorbidity should also be tackled well in advance. Then we come to Chinmai, where this uterine artery Doppler, 11 to 14 weeks, okay. Somehow, the scan is the only thing that is the patient and the family is wanting right from the start to ask us again and again, is everything okay? Is everything okay? They rely so much on the scan because they think that is on top of the list for the scan that any OBGYN will also not want to refrain from. So, how useful is uterine artery Doppler in predicting preeclampsia and also the spin-offs of growth restriction, etc.? Can you just interpret this for us and tell us how easy, how difficult, what are the challenges in interpreting this properly?
So thank you for this question, ma'am. And really, one of the advantages of doing ultrasound scans or good fetal medicine practice is points in pregnancy where you can flag off maternal problems. Like Shalini madam said, it will be good for all of them to have. She is very vocal about it because she sees the worst end of the spectrum. The people who actually reach the physician are the ones who are already extremely affected. We
Yes.
see the ones who are normal. So we are screening them. Screening is something done for normal population.
Right.
So when you do a uterine artery Doppler, as you have very rightly shown us the location of the uterine artery Doppler in the first trimester of pregnancy, very close to the bladder, just at the level of the isthmus of the uterus, you can see a vessel going towards the uterus, which is the uterine artery. Now,
Right.
uterine artery is an artery which is being pumped by the maternal heart, but the end resistance is the uterus, and the uterus itself is a very muscular organ. In non-pregnant state, it is an extremely tough organ, but in pregnancy, there is a placenta which is forming inside, and therefore the resistance of that organ starts reducing. When the resistance reduces, when blood is pumped into it, when the heart is pumping, you'll get a peak. And when the heart is not pumping also, you should get a nice flow in the diastolic phase of the cardiac cycle of the mother. What you have shown in the next picture here is the S and D, that is the peak systolic flow and the end diastolic flow.
Right.
And there is a little jump in between, which is like a notch that happens at the early diastole. The end of systole and early diastole, there is a little notch. So this is showing that there's a kind of a jumping phenomenon. So when the mother's heart is pumping, there's a lot of blood going into the uterus. And when the pump stops, that is when the diastole starts, there is a sudden retraction.
Yeah.
So this is your first indication that some resistance is there at the level of the uterus. Now, we have read from time immemorial that placenta is the cause of all the problems. Preeclampsia is a placenta-oriented disease, and placenta starts in pregnancy. So we think like that.
Right.
But your life cycle approach and all these studies have now made people think another issue, that maybe it's the maternal cardiovascular dysfunction which manifests as problems and leads to preeclampsia, because the standard definition of preeclampsia is post 20 weeks, whereas this woman had a IUD at 20 weeks because of problems that started much before that. So probably she's that one woman who may be having inherent cardiovascular dysfunction, and therefore, while this uterine artery poor diastolic flow, increased pulsatility index is a marker for poor placentation.
Right.
Now we have graduated to one more vessel, ma'am, which is the maternal ophthalmic artery.
Maternal?
Even that maternal ophthalmic artery.
Oh.
You can put a linear probe on the mother's eye and look at the ophthalmic artery in the mother, and that has now become another screening test, because the whole concept of preeclampsia is undergoing a particular evolution, where we are thinking maybe it is a maternal cardiovascular dysfunction which is getting unmasked by these changes in pregnancy.
To look
And
into the
preeclampsia,
eye.
look into the eye of the woman when she is lying down straight with a linear probe with her eyelids closed, and look at the ophthalmic artery. Even that has become a predictor for preeclampsia. But both ways, they are also a predictor of maternal cardiovascular dysfunction. So what Shalini madam just said, you can refer these patients for a physician workup as well. But in reference to preeclampsia, an abnormal uterine artery Doppler in the first trimester is a high risk for preeclampsia. And because preeclampsia and poor placentation is related to growth restriction, it is also high risk for fetal growth restriction.
Right. So, the best screening test available, as I've said here, it fulfills the criteria, relatively easy to perform with training and experience,
Absolutely.
etc. Should we now be asking Chinmay, as an additional request, please do the linear probe onto the eye also?
Ma'am, the eye part is still experimental, and it requires an extra probe. So I would still keep it in the experimental phase now, because papers have started coming. Professor Kypros Nicolaides keeps on thinking of things, and he keeps on putting these things. So in the last few years, it has come in. We have done a preliminary study in our center also and found some promising results. But there is no excuse now not to do a uterine artery Doppler like what you have shown for all pregnancies in the first trimester scan, because there are no machines which don't have Dopplers anymore, which are
Right.
used for
But
fetal
again, I
scanning.
come back to now the smaller hospitals somehow, they're doing little and little as the time goes by, and people are going to the chains of hospital and or tertiary care hospital where other departments are also there. So if the ophthalmic department is having, we can extend a part of your study into some of the centers of maternity
Absolutely.
practice in the multi-speciality, so that as how it was said for magnesium, we can also gather, solid data on these lines as well. So well said. So now you find out that, okay,
Yeah,
now,
madam.
yeah.
Madam.
One point.
Even in the primary centers or what, we send this type of patient for fundus examination.
Okay.
So as she is telling that ophthalmic artery, we do the fundus examination for this type of patient routinely, at least once in 3 months, like that in the teaching hospital. And one point I want to ask Dr. Chinmay, what will be the findings with the ophthalmic? You told no, we are seeing that ophthalmic artery findings. What will be the
Yes, ma'am.
findings?
So, ma'am, it has systolic peaks. There are peak systolic velocities. There are two waves that come, and we take a ratio of the two waves, the PS1 and the PS2. We take a ratio of the two waves, and then we see how good the maternal cardiovascular function is at this point in time, because it's a vessel which is very easily accessible. So we can assess that, and if there is a problem that starts at that point, then it is an indication that the mother's system is developing risk factors for hypertension, and she needs to now have prophylaxis for that. So it's a study going on. We haven't started in clinical practice completely, but I'll come back with better data next time.
Yes, and also we will probably expand it to those who can do it.
Absolutely.
And also the fact that the fundus examination is done as a routine is a good thing, because if in primary health centers it is done, and there could be an opportunity for at least an expanded use in these kind of patients to refer them for something to look into the eye. That is the major message that we are getting from the initial part. Correct measurements of BP, cross referral to a physician for extensive workup of the background of that. Never miss a GDM, which could be a comorbidity, and also do the basic of the uterine artery Doppler. But also in the future, we may expand it to the fundoscopy
Maternal
of the major organ, but also the ophthalmic Doppler, as how maybe in another 5 years that will become.
We are doing ophthalmic artery Doppler here in Lady Harding also. It is very simple. The learning curve is very simple. It is not as difficult as the uterine artery. You just keep the probe and 3 measurements are taken. And now they are doing, and this is not to be done by only ophthalmologists. Anybody can do it. So it's a point of care. It's coming up as a point of care for picking up patients who are having high risk for all these.
This is an excellent input, PK. So, Chinmay, you've already got in your multicentric one more center, Lady Hardinge, and two great researchers putting their heads together. We may have more to discuss in the subsequent webinars as well. And in the next webinar, I'm going to invite Dr. Bellard also to give some more practical points, since he's raised so many questions. He has to find the solutions also in a right perspective. So that's fine. No, this is a great input and a new evolving trend, so to say, which will add value to the further thinking on cases like these. So now all the panelists have a quick look at what is put on this slide. Adjunct preventive strategies for recurrent preeclampsia. We all agree that recurrent preeclampsia is a possibility, and the prevention is better than cure. And we've done some tests to find out that whether she's again, already requiring any of these. Who out of you, I'll just name each one of you, give your inputs. Low dose aspirin to start before 16 weeks, calcium carbonate, because again, the deficiencies and the preeclampsia connects are known, but we need to supplement in good dose, like 1 to 1.5 grams per day. Magnesium, 200 to 300 milligram, if deficient or at high risk, which we actually don't know whether she's deficient or not, because it is supposedly to support the endothelial and vascular health, as PK has already outlined. Lifestyle, of course, because physical activity, low sodium diet, weight management, which will optimize the metabolic profile. So we go with Sampath first. Sampath, which one of these you will give or not give?
Everything, madam. Low dose aspirin we are starting once the heartbeat is started, and the calcium routinely we are giving, and the lifestyle also. But recently, as of now, within a year, we are starting even with the magnesium. Magnesium is also nowadays started at the iron. Everything is started in the first trimester nowadays.
Great.
For this type of cases.
Yeah. Where Vidu?
Yes, ma'am. I would definitely, lifestyle is the most important thing. I would definitely say low dose aspirin in this patient because she has a previous history of preeclampsia. Magnesium plus minus because I am not starting in routinely in the first trimester, but the calcium, yes, I can. And vitamin B supplementation is another thing I would like to add.
Sure. Chinmay?
Ma'am, low dose aspirin for sure. Lifestyle is very ideal, but I don't know how much we can implement it because our pregnant women don't do all that what we tell them.
Sure.
Calcium supplementation, ma'am, because of history of preeclampsia, we do. Like Dr. Vidu said, I have not ever given magnesium separately, but most of these supplements come with micronutrients and vitamins and minerals. So, sorry.
Most of the calcium are, having magnesium.
They have some magnesium, but
agreed.
I haven't thought so much about it so much.
Sure. Shalini?
Now we have given one dissertation topic, madam, with the magnesium.
There you go.
Recent studies.
Great. So we have lots of work at Lady Hargent and also with Sampath Center to see how these studies evolve and how this thought process consolidates. Shalini? What would you as a...
We never gave magnesium such importance, I agree with aspirin, I agree with calcium, vitamin D, I agree lifestyle, obviously we start talking about it first. But then magnesium was something that we never gave too much attention to. But, now that we've been talking about it and now that I read about it, I recall a few of my obs colleagues who refer their GDM patients to me. I have seen magnesium on their prescriptions. So I think in Delhi also... magnesium supplementation has been started because I get referrals only when they have GDM or thyroid or all those things. But I do see a lot of magnesium prescriptions these days.
So the prescription flow has started. Yes. So this is a very good rapid feedback from all the four panelists. Yes, no, and then I have not particularly asked Piki. Piki, do you want to also say whether...
Ma'am, till now I
want to add magnesium or what you'll do?
Till now I have not used, but in high risk patients, as we were discussing, the patients who the high risk profile that we discussed for the previous patient, and the ones PCOS and already elderly patients, obese patients, previous history of hypertension, diabetes, previous stillbirth, in those patients I will think of adding. But after doing more research.
There is some thought process, some scope for maybe adding this. So now again back with Chinmay. The patient is, I told you, the scan is something that they love to do from one center to another. You've also done, you looked into eyes also, but she goes somewhere else and she gets this and puts it in front of an obstetrician who cannot figure out what this should mean. Can you just explain to us, Chinmay?
Yes, ma'am. So in the first trimester screening, the first three things that A, B, and C,
Hmm.
they are talking about the uterine artery parameters. So when
Yeah.
we do a Doppler, if you saw the previous picture which ma'am had shown, just the picture itself was telling us many things. You had a peak on top, and then you had a notch, and then you had the end diastolic flow, which was like a jumpy diastolic flow. So it just gives you a visual impression. Whereas these pulsatility index and resistive index, they are numerical values of how we quantify a Doppler thing. So it is the the difference between the systolic and diastolic velocity divided by the average velocity, that is pulsatility index. Resistive index is a similar thing, which is divided by just the peak, end diastolic volume, velocity. What we do is we use pulsatility index nowadays because it is always a number. The
What it should show?
It just shows how strong the resistance of the end organ is to the flow of blood to that organ.
So
So if you have a high
what will you be
pulsatility,
happy with, Chinmay? Which reading you'll be happy?
low pulsatility index but again it depends which vessel you are looking at. If you are
Right.
looking at a vessel where you want better flow, then you want low pulsatility index. For example, the uterine artery, I want a very low pulsatility index because
Right.
I want less resistance in the uterus. For umbilical artery, I want low pulsatility index. But for middle cerebral artery, I want high pulsatility index because I want the resistance to be high there. So it depends on what we want to see. For the purposes of uterine artery, we want a low pulsatility
Low
index.
pulsatility.
How do we see? So we measure it. So you have given centiles here. So I would want the centile of pulsatility index to be less than 95th centile. So whatever it is showing, it should show less than 95th centile. Resistive index is similar to pulsatility, but we don't use it because statistically it becomes useless when the diastolic flow is zero. So it cannot be that pulsatility is great and resistive is bad. It can't be like that. But
we can do without these
statistically,
also, huh? If you just see
we
the
can do
notch.
without the resistive index. The best thing nowadays, ma'am, is the softwares are giving us what is called multiples of median. So
MOM.
multiples of median is the easiest to, I think, quantify, just like you have put for beta HCG and PAPA downstairs. For uterine artery also, the software can calculate it itself. So when the pulsatility index is more than 95 percentile, that time the multiple of median will be more than 1.5 moms. So just here, like you are showing in beta HCG and PAPA, you have them from 0 to 1.5, you have them located there. So
Right.
if the pulsatility index is more than 1.5 moms, then it is high. If it is less than 0.4 moms, that it is low. So for our purposes, we are interested in low PAPA. We are interested in high uterine artery pulsatility index. Beta HCG is part of the Down syndrome screening. For preeclampsia and other conditions, we are only interested in the uterine artery and the PAPA.
Right. So then, the pulsatility index, as you said, for uterine artery should be
Less than 1.5 multiples of median for that stage of gestation.
if the software gives that. Otherwise,
the
also
software-
it is better that not to confuse the patient. If we cannot understand, we better, check it out. But then the pictures of that notch is, it's
Is
like
important.
easy to go with.
And another important thing we have to tell the patient is there are two uterine arteries. So sometimes one compensates for the other. So sometimes it is high on one side, but when you take the other side and you take an average of the two, the actual measurement is still within normal limits. So pulsatility index in uterine artery should be measured on both the sides, and the average of the two should be taken as the final pulsatility index. So when it is high, we just explain to the patient that there is high resistance to flow. So please take some precautions.
Okay, one-sided uterine artery showing high resistance, you will not start with aspirin.
No, ma'am. We take because you have to take the average of both. You have to take the average of both, and that is the final pulsatility index which you are calculating. So just unilateral increased resistance is not enough for us to say.
Okay, great. So this is, I think, quite understandable that, because aspirin nowadays, even based on history, also we start in many cases, as how, even in this case it was started. It is to err on the safe side rather than
Side of
sorry
caution.
side. That's how it has become. So I don't know if all panelists would agree on that, but that's the ground reality. So now initial assessment and protocols we finished. Magnesium supplementation guidelines we do not have. Aspirin, calcium we've agreed upon more or less. Monitoring plans, lots of lab tests and ultrasound and BP measurement. Referral and escalation criteria also has been discussed, and we have to really, these patients also can go typically shopping from one place. Please do your documentation and the follow-up also. You may need to spend a little more time to assess what's going on, the past and the present, and what you will do in future for such a case. The deficiency may be subtle in presentation, but profound in consequences, what we say. Now we come to again another real life situation. Growing evidence of deficiency is there. Now this is an Instagram poll which somebody has put. Then, do you have fatigue, cramps? Are you not being able to eat better? Do you have diabetes, renal disease? Then it means you have subclinical magnesium deficiency. Your doctor may not say. So you say yes to this, then you please go and ask your doctor for magnesium deficiency. Does it happen in practice, Vidu?
Ma'am, these all things sometimes are related with iron deficiency also. There is low ferritin levels or the hemoglobin levels are low, which we find quite common in our, kind of patients. Yeah, is also very common. But yes, people do ask us कि अब नींद नहीं आ रही तो मैम मैग्नीशियम ले लें. That's the most on the internet.
Because वो Instagram से पढ़ के आए हैं ना, that because this Instagram is telling them if you have any of these, then you have magnesium deficiency. Then for them that is enough. Yeah.
I'm not able to sleep, so shall I add magnesium to my diet? So what to say?
So this happens in reality. Sampath, Tamil Nadu patients.
No, madam. Normally, all patients will tell this fatigue, cramps, and everything. But since we are doing the dissertation on that for that patient, now we are asking for all patients itself. Anyway, they will tell yes for fatigue, cramps, and the poor nutritional status. They will not tell that. We have to find out.
Sure. Okay. So mostly it will be yes. So it can be iron deficiency, it can be general nutritional deficiency or not eating right, or it can also be magnesium deficiency. Shalini?
Same, ma'am. In the north, I think magnesium is kind of a sleeping pill. Over the counter, you see all those GNC supplements and everything with magnesium for sleep. So in the north, usually patient will ask for magnesium only if they have cramps or if they have a sleeping problem.
Okay. So sleep disturbances also, many I have found in the psychologists and psychiatrists prescriptions, also the magnesium. Chinmay, anything to add on this?
I think, ma'am, I mean, it makes sense that if somebody has deficiency of one thing, it'll probably be a combined deficiency of many things because, and this one is difficult to document, but the theoretical, support for magnesium is very strong. So it has led to this.
Yeah, because half the questions I've put because the patients are only coming and then we are in a jam because we have to respond in a appropriate and a scientific way beyond the instas and the social media. So baseline evaluation sometimes is done by the patient herself, and she comes with this report. Do you ask her to ignore it? Do you encourage her to take magnesium? This she will definitely ask for diet advice, or she will only find out and come. So all of these. And then question to Shalini is checking renal function before supplementing magnesium, not only with renal impairment, or even without that. Do you have to always check for renal function?
Yes, ideally
Casually give
a
magnesium?
baseline GFR assessment and a urine protein creatinine ratio is very important. UACR is always very important because we know magnesium excretion is essentially the kidneys. So I think a baseline renal assessment is always important, especially for these patients, because with preeclampsia and all these, you will see a decline in renal function also. So you need to have a baseline renal function. And then as you monitor these patients' assessment of renal function, especially if you're going to give magnesium, that is where the GFR becomes very important. So I think to prevent magnesium toxicity, you need that basic renal assessment routinely, I think every trimester.
Yeah, I think somebody had already mentioned 200 milligram of magnesium is causing so much GI effects. So today, alternate days is what Bella said. Then somebody we can divide it into the dosages
with
and
magnesium toxicity, sudden cardiac death is is a dreaded complication of magnesium toxicity. So I think we need to be a little more careful.
So with caution, yeah, because there are some papers 2012 to 2021 who are saying ensuring sufficient magnesium intake is not merely a preventive measure, it's a fundamental necessity for sustaining physiological equilibrium. Lots of pictures that PK showed, which really took us into the depth of what magnesium's role could be at the cellular level, which makes us really, want to think and rethink. And when we agree that magnesium evaluation we have already discussed that it cannot be assessed by the serum thing, because the intracellular magnesium analysis, now newer techniques are coming in, RBC magnesium level, intracellular magnesium analysis with the lymphocytes, muscle biopsy, non-invasive intracellular mineral electrolyte analysis, EXA test it is called. The way the tests are, there are some laboratories with, there's a whole book which is given to them, page by page it has analyzed so many things head to toe. There is a one or two chains of mm, investigative laboratories which just as a part of master health checkup, they will do everything, and they may be also getting into these intracellular newer techniques of magnesium evaluation. We don't know whether what is to be actually told about this, but if she already comes with it, maybe you will look into it deeply and see what it's telling you, and maybe rethink on what to do. This mechanisms have led to a growing interest in magnesium supplementation, because we can actually figure out whether she is deficient or not. So the normal, the test level serum magnesium, maybe 0.75 to 95, most used tests, easy to perform, widely available, but not going to be good for interpreting the deficiencies. Iodized magnesium measurement, the level shown here, measures biologically active magnesium better than the total serum magnesium. Then you go to the red blood cell level, reflects long-term magnesium status, more reliable than serum magnesium. Do 24-hour urinary magnesium excretion, assesses renal magnesium handling, useful for distinguishing between deficiency, renal loss, etc., and also a caution for the toxicity. So if we say magnesium does this, that, and the other, reduces systemic inflammation, improved endothelial function, metabolic benefits, etc., then what is the star rating that you will give? Chinmay?
Ma'am, I will give
Magnesium,
it.
the insulin sensitivity is improved, supports glucose metabolism, which is particularly beneficial if there is underlying PCOS and metabolic syndrome, as how outlined by Piki also. Do you say it has no value for me? 3 stars, as yet, 5 stars?
No,
What do you
I don't think the star rating is a justified thing here, ma'am, because you see, ma'am, it is important. So it is like salt in your food. I mean, what is the star rating for salt in the food? It has to be there.
Yeah.
It doesn't have to be more. It doesn't have to be less. If it's persistently less, it is going to lead to some problems. You cannot only concentrate on the salt part of the food, because everything else is important.
Right.
So this comes as I would consider it, I'd give it like a 5 star, because wherever it has to be there, it has to be there.
It has to be
It
there.
does
Agree.
so, and it doesn't have to be more, it doesn't have to be less, like everything else. So individually, now since we are discussing only magnesium, we are focusing only on magnesium. But when we are talking of the deficiency, I think the deficiency is a part of everything. We do not have isolated magnesium deficiency.
Correct.
It's a woman who is underfed, who is nourished for various reasons, or badly nourished. Nowadays, we don't have undernourished people. We have badly nourished people because they have bad food habits.
Okay, I want to
So,
flip this question to Piki and Shalini in a different way. If we actually get to the diagnosis of the red blood cell magnesium levels, okay, long-term magnesium status, it says, if this test becomes available, then do you think this has any value? What is the value that you would give that? Piki? If she's there, or Shalini?
After, if we can get the RBC magnesium level deficiency is reported, then I think it will be a very good idea if we can supplement her, because it has shown definitely that it is going to improve the insulin
Excellent.
sensitivity and HOMA-IR. It
Sure.
will be very useful. And
Oh.
progression to type 2 diabetes and metabolic syndrome and all the cardiovascular diseases may be prevented if we supplement.
Excellent. Shalini?
I agree with Dr. Picky, ma'am. Only thing is diabetes is multifactorial. Simply supplementing magnesium alone, yes, studies will show its association with GDM and progression to type 2 DM, but supplementing only with magnesium may not be the only thing that will prevent the progression.
No, we agree.
And yes, I
That is
agree. If
understood.
there is a documented hypomagnesemia, definitely magnesium
It has
supplementation
value.
should be done.
Yeah. Yeah, because see,
Agree.
magnesium is now into a big circle that it does this, that, and the other.
Yes.
If those
Everywhere.
things
It's
are
like
true.
vitamin D now.
Exactly. Yeah.
Yeah.
So,
Everywhere.
Exactly.
But
Vidhu?
MNT and everything else has to be there, Dr.
Yes,
Shalini. Everything.
100%.
Yes, yes.
100%.
No,
Along
no,
with
I agree.
magnesium supplementation.
Means how much important, say, we don't measure it and there are no simple
Yeah,
measuring. So having said all that, if it is measured, if it is deficient, would you like, does it add value to supplement magnesium?
Yes.
Is it better
it
besides all
should.
other things?
That's
Definitely.
what the literature is
Definitely.
showing. Yes.
Definitely. Yeah. So,
Uh,
Vidhu?
it has-
Yes, ma'am. And
Yes.
Normally, we don't do that serum magnesium. If you
Huh.
do and find out that if it is reduced, it is a point that we have to supplement.
Sure. Excellent. Great. But again, I have put in a word of caution. Avoid over supplementation. More than 500, though, it's a no-no. Gastrointestinal upset, hypotension, electrolyte imbalance. Watch for magnesium toxicity in patients with renal, impairment. All these, So we need to also, somewhere in our mind, be cautious about that. So this goes already. Chinmay has mentioned fetal neuroprotection. Tell us something more, Chinmay, in your practice, neuroprotective benefits for the fetus.
Yes, ma'am. So this has come in a big way because earlier we used to give magnesium sulfate to the mother as a prophylaxis for eclampsia.
Right.
Only the ones who had severe preeclampsia were given this. But now the role of neuroprotection has come in a big way. So it is unquestionable before the gestational age of 32 weeks, between 32 and 34, still doubtful. And after 34, people don't want to do it. But the reason we give it is because a very premature baby has a lot of problems in the neurodevelopmental delay paradigm. So when we give magnesium, magnesium is the natural antagonist to calcium. What happens is the lot of influx of calcium into the neurons leads to problems with neurological development, and magnesium helps in that membrane stabilization.
Right.
So there is something called there are some receptors, particular receptors, which are that entire paradigm helps in reducing the calcium influx into the thing. So before delivery, it is almost given the same way like preeclampsia. We give a 4-gram loading dose and then 1 gram per hour for 24 hours. And it should be in the system for at least 4 hours before you plan a preterm delivery. So neuroprotection has become really, really important, and that has improved the overall perinatal outcome for preterm births.
Excellent. Thanks, Chinmay. Sampath?
Yes, madam, we give only for the preterm, not for others. That is, as she told, the same thing, 4-gram IV and 1 gram per hour
Yeah.
for the preterm only. But this magnesium for it, nowadays it is not the prophylaxis for pre-eclampsia or eclampsia. It is the treatment.
Yeah.
There is no prophylaxis of magnesium sulfate, whether it is with chart regimen or suspend regimen. It is the management. No prophylaxis magnesium.
And Vidhu, in your infertility practice, many may be iatrogenic preterm. You may have to decide to pull them out earlier than dates. Would you consider the magnesium for
now
neuroprotective
it's a
benefits?
rule, ma'am. It's a rule. Yes, before 34 weeks, if you deliver, it is better to give them the neuroprotection.
Excellent. So, because this rule has not come into the protocols of many of the smaller, medium-sized hospitals, as Sampath and myself would have noticed in our Manita settings. But this is a thing that, because many babies are indeed pulled out at 33, 34 weeks, and this may well be one of the very important indications for the use. Now, quickly, the various arteries that you told, Chinmay, later in pregnancy, what happens to the flow in these?
So absolutely, ma'am. And like I was saying, see, you had raised the issues of pulsatility index and resistive index. So in nutshell, uterine artery is the flow from the mother's heart to the uterus. So the uterine artery is reflecting the resistance of the uterus and the function of the mother's heart. So if the uterine artery is bad, then the mother's heart is taking a lot of load, and then she becomes at risk of preeclampsia. The other 3 vessels are fetal vessels. Now the ductus venosus is a vein. It is a vein. It is an extension of the umbilical vein. So from the placenta, the blood goes to the baby through the umbilical vein. So the umbilical vein is a big vessel, but there is a small conduit called ductus venosus which it connects to the inferior vena cava. Most of the umbilical vein goes to the fetal liver, and the rest of it goes into the fetal heart through the ductus venosus. So the ductus venosus, these waveforms, as you have shown here, these are actually reflective of the fetal heart.
Yeah.
So you have one S wave and a D wave and an A wave. So that S wave is fetal cardiac systole. So when the fetal heart is contracting, that time the AV valves are pushing into the right atrium of the fetus and leading to this first S wave. Then when there is a diastole in the fetal heart, the valves are opening and there is a jump again and you see the D wave. And finally, when the fetal atrium is contracting, the last phase of cardiac contraction is atria squeezing, where it pushes blood into the ventricles. At that time also, when you have a positive flow, that means the oxygenated blood is flowing positively into the fetal system, and that is good. As you can see in the next picture and the next picture, that A wave is becoming smaller and finally getting reversed. So that is a bad phenomenon where the oxygenated blood is coming back into the placenta. The fetus is not getting that oxygenated blood. So that is bad. Then you have the middle cerebral artery. Middle cerebral artery is the central, it's a branch of the internal carotid artery, and that is maximum blood supply to the cortex of the fetal brain. Now, nature has designed the brain in a way that it functions under very high resistance, and you do not have vasodilatation in the brain under normal circumstances. When there is less oxygen or a condition of hypoxia, the brain has vasodilatation. When carbon dioxide increases in the brain, you have vasodilatation. So the normal resistance of the middle cerebral artery is high. So you see the picture on top, which is high resistance. What I was alerting you against in uterine artery, I am in the middle cerebral artery. So the middle cerebral artery should normally be high resistance flows because that's how it is designed. When the resistance becomes less, as you can see, the increased diastolic flow in the middle cerebral artery is an indication of vasodilatation, which is again a surrogate marker for hypoxia. So middle cerebral artery tells us about how the baby is compensating to hypoxia. And this umbilical artery is the vessel which is flowing from the fetal heart to the placenta. It is taking deoxygenated blood from the fetus to the placenta. So this normally it has a nice flow because placental resistance should be low, and this is a clearing vessel. It clears off deoxygenated blood, and the systole that it represents is the systole of the fetal heart. And so umbilical artery, when it is normal flow, is great. When the placental resistance is very high because of a poorly formed placenta, you have low diastolic flows because when the heart is not pumping, the diastolic flow will be less. And similarly, you have absent diastolic flow and then reverse diastolic flow, as you can see in the 4 pictures that you have shown there. As there is reverse diastolic flow, what is happening? The deoxygenated blood is coming back to the fetus. It is not getting cleared into the placenta. So the first problem that will happen will be the umbilical artery abnormality. That is the peripheral resistance of the baby. The next problem that you will have with the middle cerebral artery decompensation by things. So that is called the cerebroplacental ratio alteration, the umbilical flow and the cerebral flow. And when ductus venosus becomes abnormal, that is bad inflow of oxygenated blood, that is the final calling point. Once you have absent diastolic flow or absent a reversed A wave in ductus venosus, you are looking at fetal death if you don't intervene. So that is the way the Dopplers work.
Super. Very well explained, because this is, when I said investigate, interpret, and intervene, because we know that investigations with respect to the scans, many fetal medicine centers are there, experts like you are there. Any such case, we would cross-refer and have the investigations done there. But unless we know how to interpret and when to intervene, I think the whole thing, loses the point. So very, very well explained, Chinmay. Thank you so much. So now the last 2 slides, I want to say that complementary to iron and calcium, perhaps iron and calcium is well in our armamentarium of prescription. Magnesium, with all the due cautions that we have discussed, though it provides, it complements both by supporting cellular energy, metabolism, enzymatic function, electrolyte balance, and leg cramps came like on top of the list anyways in the poll question also. So we are not yet sure whether we will blindly support the supplementation. But as we said, again, I emphasize on the word evolving. What we may say today may change tomorrow. So let's be mature enough to keep that in mind. And there's a whole chart here of metabolic advantages of supplementing with magnesium, reproductive advantages with all of those, inclusive polycystic, menstrual cramps, etc., and high-risk pregnancies, the whole list given here. So magnesium deficiency is not just a biological anomaly, it's a silent disruptor of multiple physiological processes, complex and difficult to understand, but it has far-reaching consequences. Proactive approach should focus on oral magnesium to maintain adequate intracellular stores. As of now, we don't know the status of the intracellular stores because the serum values may lead us, in an inappropriate track. And preventive strategy, as how Shalini has also expressed and PT has also said, risks associated with future cardiovascular diseases, diabetes, etc. May prevent these worsening conditions. So when I say, do you agree? I'm going to quickly skip this slide because many points that have been discussed very honestly make us rethink about the evolving trends in high-risk pregnancy management. In fact, each one of us who have now probed into the literature have recognized that magnesium supplements may become increasingly important in the management of high-risk pregnancies, possibly on par with iron and calcium for several emerging reasons. And individualized supplementation remains the key. And we close with reminding everybody the theme of innovation to implementation to discuss, debate, and decide more on several such topics and the real world impact. We fondly, from Team Artists, invite you on 14th and 15th of August for the Cutting Edge Conference in Hotel ITC Gardenia. This is a friendly reminder for the same, and I would want to close with the firm belief that all the panelists and all the delegates and the stakeholders at large, inclusive of the pharma companies, have is good health and well-being for all across the lifespan. So the more we discuss, the more we turn our head around the newer molecules and their impact on making this world a better place, we will be moving the needle in the right direction. Thank you ever so much to Sampath, Vidu, Piki, Chinmay, Shalini. I think it was I am very delighted with this evening's discussion because it is really more food for thought. We have been doing a few things. Should we go back and forth to reflect and revise? That is the main take home message from this panel. And there may be just two questions I may take from the audience, which are listed here. Even Bellat says that his candidate has done the dissertation on ophthalmic artery. Sampath and Bellat should now exchange some notes. If we give all tablets which contain many vitamins, like the Pregnacare tablets, etc., it'll anyhow have the trace magnesium. Yes, that's a thought we discussed. What about abdominal cramps with magnesium supplements is a question that Preeti Singh is asking. And we have spoken enough about cramps. I think the duration of these dosages in high-risk pregnancy is also being spoken about. But other minerals, even like selenium, is also important. So now, some more webinars, some more multivitamins. And I think, and of course, everybody has complimented it's an excellent session. So I should thank each one of you for the same. But, the idea of shifting from IFA tablets, iron folic acid tablets, to the MMS, multiple micronutrient supplementation. That is what is the latest recommendation of WHO. The government, some of the state governments are very seriously looking into that. Though India is manufacturing that and exporting, the regulatory authorities here and the recommendations from the government are not yet for multiple micronutrients. Maybe all these tagged on and added on may make a case for shifting from just iron folic to multiple nutrients. Now, if I have just very rapidly gone through all the questions because I think many of them by this very esteemed panel were already answered even prior to the panel. That's a great thing, really. If now quickly in next 2 minutes, if the Farmet team can flash the poll questions, and we will be quite happy to see who in the audience is awake. What is your preferred form of magnesium during pregnancy? Okay. very small percentage. 3% is saying do not prescribe, but most agree with the combination with other minerals, which, with in perception, it seems safer. Chalo, ye bhi thoda de do. It's like that. And highly bioavailable magnesium is the preferred one. Oral calcium supplements with small amount of magnesium oxide. Now I think everybody has gotten conscious and cautious about the side effects, Shalini. So
Yes.
think ophthalmic, think renal are the new thoughts
Yeah.
which have been posed. So yeah, so this is great. Yeah. So can we, yeah, these results are already shared now. And then the next is calcium folic acid. Do you believe that magnesium is becoming the next calcium folic acid or iron in the antenatal supplementation? As I said, the thinking process has begun, and we have started thinking 5 years ahead. That many are strongly agreeing and some are agreeing that if magnesium has so much to do, and like vitamin D, if there is so much deficiency, maybe we should give it a significant thought of how to assess it, how to supplement it, how to add value, especially the already accepted neuroprotection, etc., which should become the norm for the preterm. Yeah, this is good to go. The next one. Yeah, the results are shared. Strongly agree and agree form about 80%. Disagree is 7%, and uncertain is 14%. Fair enough. I think, the message has been well absorbed and honest answers. Do you feel today's session was insightful and helpful in improving the quality? Oh God. Audience, I love you. 100%. And this is thanks to the brilliant panelists who are here, who have taken us through the pluses and minuses. Just, this is really nice. Good. Any last one more question? Yeah, we are very happy. Today we'll sleep well. Do you feel today's
You
session
made it
was
lively, madam.
insightful?
Because of you,
There
it
you
made
go.
it
We
lively.
should see whether webinars increase the serum cell magnesium levels. If you will sleep well.
Okay. Do you have any case study done on oral magnesium supplementation in high-risk pregnancy, which could be discussed in the next webinar? Now, the forerunners for that, beyond Piki and other panelists here, are Sampath and Bellad, for sure. And
Yes,
yeah, so we may be adding more value to that, because 20% says, yeah, they have some cases, the dissertations, etc., but 80% do not have the cases as yet, because it's not very easy to actually document in every setting. So whether it be for whatever indication, we have work to do on this. That is the final conclusion for
If that
sure.
method of RBC magnesium levels can become more available,
Yeah.
then we can see whether there is a deficiency in the beginning and whether the supplementation is improving that level later on. And if there is any scope of toxicity, then
And
that would be a good way
sure.
to do.
Yeah, and also like Piki said, do you have any case study? Yeah, this we have just discussed that few have case studies, which we will also take up in the next webinar maybe. But as Piki said, the point of care. So we have also already experimenting with the point of care ferritin testing. And it's showing 98% validity, because most of the places we do only the hemoglobin, and underlying ferritin is not estimated because it's not accessible, and iron deficiency per se is not picked up. So if there is a point of care, and we have harvested 63% more eligible candidates for compliance with oral iron or parental supplementation straight away, if there is a limited time that is available, especially in pregnancy. So these kind of evolving and emerging innovations will quickly go into implementation, because then today what we are thinking is not at all doable. Tomorrow, yes, it may be available as point of care to reach the last mile. So it's so worthwhile thinking about what we could do. And as a formality, it's my duty to officially thank, because the thank you slide is there. So it has to be flashed with a lot of sincere appreciation to the team artists and Farmed, which have really chased everybody for registering for this, making sure that they understand that this is a food for thought and it'll just get your antennas up to see what the future could hold. So that is a great attempt at onboarding, and the recording also, I'm sure it'll be soon available. And on behalf of Dr. Divakar, myself, and Team Artist, we sincerely acknowledge the readiness with which the keynote speaker, Dr. Piki, and the panelists, Dr. Shalini Jaggi, Vidhu Mudgal, Sampath Kumari, and the one and only Chinmay Ratha, volunteered to jump into this rather tough aspect, because this is not what we can speak blindly from what we do in everyday practice, because this is something that needs more reading, more thinking, more deliberation, more evidence, more work on this in totality to see that, we need to move further. There is Trupti Mukherjee who has raised her hand. So Trupti, anything from your end? There is a hand raised. Is it by mistake, or do you want to say something, Trupti? Or maybe she's asking us to stop. Which is
yes.
No, I think today's session has been so interesting. I'm sure nobody wants to stop, because I'm sure everybody is going home wiser. At least I have learned a lot. So thank you, Hema ma'am. It was great.
Thank you so much.
Ma'am is so
If
active at
any of you
9:45.
want to make any final comments, please go ahead. Sampath?
Yes,
Sampath
madam.
said something
Yeah,
now.
magnesium is must. I will tell. Not for this, because we are doing a dissertation. With the result, I will
Okay.
meet you in the next webinar.
Oh, okay, good. Anybody else?
As you
Any
have
closing
said very
comments?
rightly, ma'am, you said the idea is to evolve. So I'm reminded of Swami Vivekananda's statement that every idea, it goes through first ridicule, then opposition, and finally acceptance. So at least I think we have now reached the stage of opposition where people are starting to oppose the idea. Maybe this is a lot of toxicity. So when we will investigate, at some point we'll find the acceptance there. But unless we think, unless we evolve, it is never going to happen. So thank you for forcing us to think. Otherwise, we are all so comfortable in our zones that we don't think.
I think this is a magnificent closure for magnesium discussion.
Yes.
So I really
Absolutely.
appreciate everybody's wholehearted participation. And thanks again to those specific names which I have not mentioned. And of course, without the delegates provoking us with more questions, we would not have had such an interesting discussion and the panel. So thank you very much, one and all. Namaste.
Thank you, ma'am.
Thank
Thank
you,
you.
madam. Thank
Thank
you.
you.
Chinmay, always it is pleasant to listen to your thoughts and answers.
Thank you, ma'am.
Thank you.
Thank you,
Thanks,
madam.
everyone.
Good night.
Thank you so much, ma'am.
Good
Good
night.
night.
Thank you.
Bye-bye.
Good night.
Thank you.
Bye bye.